Okay. Good afternoon, everyone. And I'm actually very privileged to be a part of today's teaching program. And I thank Dr. Kalpana for having me in it. In fact, I admire you, Kalpana, the kind of enthusiasm you have for these programs for our DNB students are in fact helping a lot of DNB students. So thank you and keep continuing it. It's not moving. Just hold on. I think I got stuck.
No,
okay. Yeah. All right. When we talk about history, in fact, it gives us an opportunity to acknowledge our pioneers. So just to start with, the word anesthesia comes from a Greek word called anesthesos, which means inhibition of sensation. And this was coined in 1846 by Oliver Wendell Holmes. And same year, on 16th October, we had the first successful anesthesia with William T.G. Morton, and that became one of the greatest gifts to mankind. The origin of ophthalmic anesthesia dates back to 1884, when Carl Kuhler applied cocaine drops directly to the surface of the eye. Worldwide, the most common ophthalmic surgery is cataract surgery. So today my talk will be mostly focused on cataract surgery in adults. Pediatric is a different topic altogether. So I have not in fact included pediatric in my talk. So the increased demand of cataract surgery is because of the rapidly growing elderly population, development of intraocular lens implants, especially the foldable ones, the widespread surgical techniques, and the equipments in the form of microscope and phacoemulsification. In India, 82% of Indians aged between 75 to 83 years are affected by cataract, and it accounts to 80% of blindness in India. Hence, we have taken the initiative with WHO Vision 2020, the right to sight. And as a country, we have increased cataract surgeries from 9 million per year, which happened in 2005, to 14 million in 2020. So to anesthetize an elderly person for cataract surgery, in fact, it's a unique challenge for the anesthesiologist. Therefore, it is very important how we evaluate our patient, how we optimize them, plan our anesthesia, to execute our anesthesia, and to discharge our patients safely without complications. Before we go into what kind of anesthesia, what are the different blocks to be given, it is extremely important to understand the clinical anatomy of the eyeball. Each orbit is a pyramid-shaped cavity with its apex lying posteriorly. Depth of the eyeball is about 25 millimeters. It ranges from 12 to 35 millimeters. The axial length of globe is the distance from the corneal surface to retina and is measured preoperatively. If it is 26 millimeters or more, it denotes a larger eye, indicating globes longer than this, there can be an easy perforation during regional anesthesia. The Tennant's fascia surrounds the eyeball and it originates at the corneoscleral junction and fuses posteriorly with the dural sheet of the optic nerve, separates the globe from the central and the peripheral conal fat, which surrounds the ocular muscles. The extraocular muscle and nerves penetrate this fascia, and it creates a potential space around the eye where local anesthesia is placed, allowing diffusion of drugs to the nerves. The orbital fat is two types, central and peripheral, which is divided by the cone of recti muscle. The central fat contains the optic, oculomotor, abducens, and nasociliary nerves. And the peripheral fat contains the trochlear, lacrimal, frontal, and infraorbital nerves. The muscles consist of levator palpi superioris and the 6 extraocular muscle, the 4 recti, superior, inferior, lateral, and medial, and 2 obliques, superior and inferior. The sensory supply is by the ophthalmic branch of the trigeminal nerve, which divides into 3 branches: lacrimal, frontal, and the nasociliary. The motor innervation to the lateral rectus is by the 6th cranial nerve, superior oblique by the 4th cranial nerve, and the remaining by the branches of the 3rd cranial nerve. And so you can remember having a formula like LR6SO43, like in chemistry. And the blood supply, the arterial supply, is from the ophthalmic artery, which is a branch of the internal carotid, and the venous drainage is from the superior and the inferior ophthalmic veins, which drain into the cavernous sinus, a dual sinus, which is close to the proximity to the eye. This is the view of the orbit, how it looks. If you look at here, the green denotes the muscles, the superior rectus, the lateral rectus, the inferior rectus, medial rectus, superior oblique, and the levator palpi superioris. The blue are indicating the nerve supply, the lacrimal, frontal, trochlear, oculomotor, abducens, and optic nerve. And the red indicates the blood supply, optic artery, ophthalmic artery, and the superior ophthalmic vein, and the inferior ophthalmic vein. Coming to the intraocular pressure, the normal intraocular pressure ranges from 10 to 20 millimeters of mercury, and 3 factors affect the intraocular pressure. They are changes in the intraocular contents, which means balance between the aqueous humor production and its drainage. Then the next one is the scleral rigidity, and the third one is the extra pressure on the eye. Regional anesthesia does affect the intraocular pressure by 2 ways: the local anesthesia inject volume and the use of a gentle pressure, especially the external pressure. Normally, you must have seen we are putting the kind of a ball device, which is called the Honan balloon, and its pressure is around 30 millimeters of mercury. And this is done to improve the local anesthesia, decrease the chemosis, or control bleeding. In fact, no massage should be given to the eye because the intraocular pressure can go up to 400 millimeters of mercury. General anesthesia can also affect the intraocular pressure directly, and the use of nitrous oxide should be avoided, where an intraocular gas bubble is used, as nitric oxide will expand the gas bubble and lead to an increase in the intraocular pressure. So what things to consider in cataract surgery? It is the age. They belong mostly to the geriatric population. It's a daycare ambulatory surgery. Patients can have from a single to multiple comorbidities. It's a high volume procedure. So fast turnover in operating rooms is high. It is low surgical risk in a high risk patient. It's an elective surgery. Pre-anesthetic evaluation, preoperative optimization play an important role in confirming the appropriate clinical condition for surgery. It's a delicate intraocular operation. Need of akinesia and a stable intraocular pressure is needed, and you need a still patient. There should be no movements, as these patients are mostly done under regional block or topical anesthesia. And failure to meet these other requirements can result in lens dislocation, loss of vitreous, retinal detachment, macular edema, and an hemorrhage resulting in blindness. So what are the challenges we face as anesthesiologists? Cardiovascular system involvement is seen in almost 78% of patients in the form of systemic hypertension, IHD, arrhythmias. It is therefore very important to know the duration of the involvement, the medication these patients are on, and the anticoagulant therapy and if they are on any pacemaker machine. Surgery is deferred if patient had an acute MI. It should be avoided within 60 days of acute MI, acute coronary syndrome, decompensated heart failure, uncontrolled arrhythmias, hemodynamically significant valvular disease until it is adequately controlled. It has been seen that respiratory involvement is seen in 17% of patients in the form of smoking, COPD. And if the patient is still smoking, it is advised to stop smoking 4 weeks prior to surgery. Endocrine disease involvement could be in the form of diabetes, hyperthyroid, autonomic dysfunction. We need to know the duration and the medication they are on. These patients can have neurological disease in the form of Parkinson's, Alzheimer's, stroke, dementia, involuntary head movement, tremors. They can also have chronic kidney disease. They may be on dialysis. It is extremely important that we need to optimize the biochemistry and the fluid status before the surgery. They can have orthopedic problems in the form of degenerative spine joint pains, which will make them very uncomfortable on the operating table. Special attention to be given to elderly male who have prostate problems if they are on 5-alpha reductase inhibitors and alpha-1 receptor antagonist, because if they are on these drugs, this can result in a floppy iris syndrome intraoperatively. So in the preoperative evaluation, the goal is to optimize the patient and handle the stress associated with surgery and anesthesia. It's a low-risk surgery in a high-risk patient. So there is a controversy on the extent of investigations to be done routinely before surgery, and this depends on the anesthesia technique and the institutional guidelines. If we have planned a complete GA, then a detailed workup as per medical illness and airway assessments to be done. Especially for airway, the dentures, loose tooth has to be taken care of. Extensive investigations for cases under local and regional anesthesia, like X-ray chest, 2D echo, kidney function, liver function, and pulmonary function may be required for patients with positive risk factor identified in the history, and informed consent has to be taken before taking the patient up. These patients can be on multiple chronic medication, which we need to continue except the anti-diabetic drugs, and the sugars have to be maintained during the day of surgery between 100 to 180 milligram per cent. In fact, there is no clear algorithm for managing patients undergoing eye surgery who are on anticoagulants. It is best to make a balanced benefit versus risk decision in each case. If these patients are on dual antiplatelet therapy for a defined period of time following angioplasty, defer cataract surgery. If on warfarin, check INR, should be in therapeutic range. Even if over 3, review the case again. So ophthalmic procedures which are considered low risk, like intravitreal injections, cataract surgeries, corneal surgeries, simple trapezius surgery, in these cases, you can continue antiplatelet therapy. Moderate risk of bleeding include vitreoretinal preseptal eyelid surgeries. In these patients, continuing or holding anticoagulation should be tailored case-to-case on case-to-case basis. High risk for bleeding include orbital, lacrimal, postseptal, and enucleation. In these cases, anticoagulation therapy to be withheld. So there are established management strategies for drugs such as warfarin and heparin. But for a drug like dabigatran, which is a long-acting oral anticoagulant with no direct antidote, potential bleeding in patients on these drugs is of concern, including eye surgery. The current recommendation is to withhold the drug for 5 days prior to performing the nerve block and surgery. Topical anesthesia is preferred for patients on antiplatelet and anticoagulant therapy. Nil by mouth status depends on the type of anesthesia, whether we are giving block, topical, or general anesthesia. Choice of anesthesia technique depends on surgical requirement and patient's medical condition, cooperation, and choice of patient. Majority of cataract surgeries are done under topical anesthesia or regional blocks. In regional blocks, we have the retrobulbar with facial, peribulbar, subtendon block, or topical. And all these, whether it is a regional anesthesia, it should have a monitored care anesthesia. General anesthesia is for patients who are uncooperative, mental retardation, involuntary movement, and patient's request. So what advantages of regional anesthesia is that the patient is discharged safely same day, good akinesia and anesthesia, minimum effect on the intraocular pressure, and a minimum equipment is required. So the contraindication to regional anesthesia is absolute and relative. In absolute, there is patient refusal, allergy to local anesthesia, and localized sepsis. Relative contraindication, disorientation or mental impairment, inability to lie flat, involuntary movement of the head, communication difficulties, abdominal coagulation, perforated globe or trauma, and a procedure over 90 minutes. In these cases, patient positioning is extremely important and appropriate padding to be done to minimize risk of patient movement and discomfort. Normally, a pillow is placed behind the knees, supporting them in flexion provides comfort to the lower limbs and back. Oxygen delivery by nasal prongs or modified right angle bar with perforation in horizontal routes provides a diffuse oxygen supply. This may also help to wash out carbon dioxide from under the drapes. Patients can be given a squeaky ball to squeeze, allowing a clear signal if they need to cough or move. Normally, topical anesthesia is given to the non-operative eye to reduce the blink reflex. If these patients are unable to lie flat, then there are two positions which we can be given: seated using a reclining chair in an upright position, or a reverse tender work position where the surgeon may stand to operate or can be seated to the side of the patient. This is our operation theater. We have a right angle bar like this so that our sterile drapes goes over it, and the patient doesn't feel the feeling of claustrophobia, and the CO2 retention and humidity all goes down, and patient is very comfortable. This is our phaco machine also behind. Coming to blocks, retrobulbar block. This block was introduced by Knapp in 1884. It is hardly used these days. About 0.5% is in use. The injection given is at the lower lid margin, just above between the medial 2/3 and lateral 1/3 of the lower orbital margin. So here one has to take care the kind of needle and the length of needle. Normally it is a 24 gauge needle with a length not more than 30 millimeters. So when you enter, you feel the first pop-up. As soon as you feel the first pop-up, you lower the needle to an angle of 45 degrees and then go medially and superiorly till you feel the second pop-up. Here the aim is to block the ciliary nerve and ganglion. Third, fourth, and sixth cranial nerves are blocked. Provides a good akinesia and anesthesia of the globe. It is always given with facial block. And there are different types of facial blocks named Van Lint, O'Brien, Nathat, and Rehman, Atkinson. All these are named after those who have invented the procedure. The most common is O'Brien, where the paralysis of the seventh nerve anterior to the condyloid process of the mandible, the needle is injected directly and to hit the bone. And while removing the local anesthesia is given, injected in the needle while withdrawing the syringe. But this block has a lot of complications. It is not popular at all these days. It ranges from mild to severe retrobulbar hemorrhage requiring the case to be cancelled. There can be respiratory depression, meningeal irritation, intradural injection with central nervous depression and autonomic dysfunction, penetration by sharp needle into the optic nerve, perforation of the globe, and contralateral emeresis. The word emeresis comes from a Greek word, means darkness, which can cause loss of vision without apparent cause. Peribulbar block was introduced in 1986 by Davis and Mendel. Two injections are given, upper eyelid and the lower eyelid. In the upper eyelid, at the junction of the medial 1/3 to lateral 2/3, and the lower eyelid at the junction of lateral 1/3 to medial 2/3. The drug is injected into the peribulbar space, spreads to the lid and other places, and it produces globe and orbiculus, akinesia, and anesthesia. And the use is about 20% these days. The advantages of peribulbar block is there is less incidence of optic nerve damage, Facial block is not needed. Disadvantages are local anesthesia placed outside muscle cone. Optic nerve may not abolish vision completely. There can be periorbital ecchymosis and a large volume of local anesthesia needed. The indications are for this block are the cataract surgery, pterygium surgery, squint surgery, and retinal detachment surgeries. Some tendon block. This is the most popular block and the use is about 50%. A congenital incision is given 2 to 3 millimeters halfway between inferior limbus and fornix. And the cannula which is introduced, you can see this cannula, it is a blunt cannula. So the injuries to the vascular and optic nerve is very minimum. It gives an excellent anesthesia and akinesia and least painful painful injection. It blocks the short ciliary nerve which passes through the tendon's capsule to the globe, gives good akinesia, and blocks the anterior nerve fibers as they enter the extraocular muscles. This is a chart which it is combined the complication of regional anesthesia. The most common is ecchymosis, where you have a swollen conjunctiva, and an implication is cosmetic, and treatment is just a little pressure that will help to resolve it. Then you can have subconjunctival hemorrhage, where signs could be bleeding. Implication is cosmetic, and treatment is same, slight pressure to be given. Allergy to local anesthesia, this can come in the form of discomfort, rash, nausea, itching. This could be life-threatening and supportive treatment to be given. Ecchymosis, sudden onset or periorbital pain, it's mostly cosmetic. We have gone through the retrobulbar hemorrhage, which could be arterial when there is sudden proptosis and increase in the intraocular pressure. If it's a venous hemorrhage, thus it is slower onset, lead to central artery occlusion and a stimulation of oculocardiac reflex. This hemorrhage can be sight-threatening as well as life-threatening. You need to postpone the surgery. There can be globe injury, sudden pain, acuity changes. Maybe this can be sight-threatening. Optic nerve atrophy, altered acuity. This leads, implication is sight-threatening. Muscular palsy, diplopia, ptosis symptoms, and their implication, deviation of the eyeball, limitation of gaze. Then we can have a brainstem anesthesia where it can be altered neurology and cardiorespiratory compromise. This could be life-threatening and therefore supportive treatment to be given if required. Coming to topical anesthesia, it became very popular. It was introduced by Fitchman in 1992. It is normally used as anesthetic drops, gels, or sponges that are applied to the conjunctival sac and gentle pressure applied to prevent loss from the nasolacrimal duct. It blocks the trigeminal nerve terminals in the cornea and conjunctiva and does not provide anesthesia to intraocular structures nor akinesia to the globe. It is very effective with intracameral injection technique with 1% lignocaine, preservative free. And the commonly available drops are binoxynate, amethocane, and lignocaine. The intracameral injection was introduced by Gills in 1992, always given as an adjuvant with topical anesthesia with a preservative-free 1% lignocaine, which is injected into the anterior chamber through one of the corneal incisions required for phacoemulsification. It provides sensory block of iris and ciliary body, and therefore reduces the discomfort during the intraocular lens implant placement. There can be transient visual loss can occur because of the posterior diffusion of local anesthesia to the retina. Hence, it is used in a very small dose. Recommended dose is not more than 0.5 ml. So the advantages of topical anesthesia, it's quick, non-invasive, it is well tolerated with patients, no complication, and patient has immediate improvement in vision and eye shield is not needed. Disadvantage, no akinesia. Patient should be motivated and should be cooperative for simple and uncomplicated cataract, and it needs an expertise surgical hand for surgery. There is something, no anesthesia technique for cataract, which was introduced in 1998 by Amar Agrawal. According to him, peripheral and superior cornea is less sensitive to the central cornea and South Asians have less corneal sensitivity due to the ultraviolet rays exposure. The major disadvantage of this was that the surgeons were too stressed and uncomfortable to operate, hence did not gain popularity. Something similar, Uterus and Carmona modified this technique into cryoanaesthesia, where all solutions are cooled at 4 degrees except the povidone drops, and an eye cold gel is placed over an eye for 10 minutes. During surgery, eye is irrigated with cold balanced salt solution. This also has not gained popularity, but in certain European countries, they are still doing this. This is a chart which shows the normal drugs which are used normally for topical and infiltration. Hyaluronidase is a commonly added drug to the local anesthetic solution to decrease the time to onset and to perform homogeneous dispersion. It is also believed to increase local anesthesia, metabolism or spread, thereby also decrease the period of contact with muscle, hence decreasing paresis, which is otherwise increased when just local anesthetics are used. It is normally used in dose of 75 units. Coming to the systemic effects of ophthalmic drugs. Now we have to remember that these drops are small, quantity is small, but the concentration of the drug can be very high. So there are certain drugs which we have to avoid in certain group because of the systemic adverse effects, especially the anti-glaucoma drug primoidine should be avoided in nursing mothers, infants, and patients who are on antidepressant therapy. The adverse effects are they can have dry mouth, tachyarrhythmia, taste disturbance, and rash. Anti-sympathotonic drugs can cause hyperemia, pruritus, foreign body sensation. Then we have these drugs, timolol, which are non-selective beta blocker, should be avoided in asthmatic patient, emphysematous patients, COPD, patients with congestive heart failure, blocks, sick sinus syndrome. Adverse effect, these patients can have urticaria, alopecia, contact dermatitis, bronchospasm, headache, and insomnia. Acetazolamide drops avoided in patients with Addison's disease, renal and liver diseases. The adverse effects are paresthesia, metabolic acidosis, urticaria, fever, depression, taste disturbance, and gout. Pilocarpine, the systemic effects are headache, vertigo, asthma. Latenprost can cause headache, tachycardia, skin rash, dizziness, asthma, muscle and joint pain. Antihistamic drugs can cause headache, nausea, and drowsiness. Antimicrobials can cause contact allergic reaction, eczema, headache, rhinitis, affect taste. Midriatic drugs can cause dry mouth, confusion, tachycardia, memory disorder, abnormal behavior in children. And phenylephrine drops can cause, especially in children and elderly population, adverse cardiovascular effects. Steroid drugs can cause cortisone, glaucoma, and cataract. Then the drugs which are on long-standing systemic drugs which can cause adverse effects on the ocular, on the eye. Chronic glucocorticoid therapy can cause increase in the intraocular pressure and promote cataract development. Antipsychotic, antidepressant drugs can increase the intraocular pressure. Hydroxychloroquine and chloroquine can have an irreversible toxicity to the retina. Antitubercular drugs can cause irreversible toxic effect on the optic nerve. Coming to monitored care anesthesia, as we know that the cataract patients are mostly done under topical anesthesia or regional block, but it is extremely important to have the monitored care anesthesias, which is nothing but a specific anesthesia service for diagnostic or therapeutic procedure provided under local anesthesia along with sedation and analgesia, titrated to a level that preserves spontaneous breathing and airway reflexes. It compromises of 3 basic components: a safe conscious sedation, measures to allay patients' anxiety, and effective pain control, and results in less physiological disturbances, and a more rapid recovery than general anesthesia. It is suitable for daycare procedure as it helps in fast tracking. It is a comprehensive service which includes all aspects of anesthesia, pre, intra, and post-op care provided by a trained anesthetic personnel. We need to monitor these patients with basic monitoring, ECG, pulse oximeter, non-invasive blood pressure, and if possible, nasal capnograph. We keep the patient nice and warm with a warm blanket. Patient positioning is extremely important to make them comfortable. We remember these patients mostly belong to geriatric age group. Therefore, the pharmacodynamics and pharmacokinetic drugs of drug administration to be taken in consideration to avoid cognitive errors, patient safety, fast recovery and discharge. Required doses of drug is smaller, onset of action is slower, and respiratory and myocardial depression can be profound in these cases. Hence, a careful titration of sedation, narcotics, a balanced technique with prevention of nausea and vomiting using ondansetron and dexamethasone for avoiding of nausea and vomiting. Coming to general anesthesia, it is a short surgical time. So fast track anesthesia is necessary for a safe choice in elderly patients. A balanced technique with short acting drugs such as propofol, fentanyl, alfentanil, remifentanil with inhalational agents like desflurane, sevoflurane, and a short acting muscle relaxant, cisatracurium or atracurium. And depending upon the surgical speed and the comfort of the anesthesiologist, one can have a laryngeal mask or an endotracheal tube. Avoidance of hypercapnia and hypoxemia, because this can increase the intraocular pressure. Prevention of coughing and bucking during induction and extubation should be avoided as it increases intraocular pressure. And prevention of nausea and vomiting with ondansetron and dexamethasone is recommended. Coming to oculocardiac reflex, which is also known as Ashner-Dagny reflex. This is a parasympathetically mediated bradycardia that occurs as a result of globe compression or an extraocular muscle traction. The afferent signals pass via the trigeminal nerve to the medulla, and the efferent pass via the vagus nerve to the sinoatrial node. Hypotension and increased atrial carbon dioxide partial pressure potentiates an increase in the incidence of the reflex. Treatment is remove the stimulus, inform the surgeons, and immediately remove the stimulus. Give an intravenous anticholinergic, check and deepen anesthesia if general anesthesia is given. May be required to give lignocaine if ventricular premature contraction are a problem. In fact, local anesthesia blocks the incidence of reflex by blocking the afferent limb. This is the diagrammatic presentation of how it happens. This is the efferent pathway through the trigeminal nerve, and this is the efferent pathway through the vagus nerve to the sinoatrial node. Coming to the surgical technique, there are three ways to remove the cataract: intracapsular cataract extraction, extracapsular, and phacoemulsification. Intracapsular cataract extraction has become completely obsolete now these days. Extracapsular cataract extraction, the cataract comes out in one whole piece. The limitation of extracapsular extraction is it's a prolonged surgery. Trauma leads to inflammation, suture distortion of cornea, prolonged convalescence, restriction to activity, and it necessitates a regional block. The recent ones are the phacoemulsification, which was introduced in 1967 by Charles Kellman, where the cataract is emulsified and then sucked out. This is the phaco machine. That's how it looks. Advantage is it's a very small incision, not more than 3 millimeters, can be performed without needles, very short duration, less inflammation, fast recovery, little restriction to the activities of the patient. This is the most recent technology in phacoemulsification, where ultrasound is used. And the technology involves where water pulses a warm balanced salt solution at 57 degrees Celsius which are propelled at the rate of 50 per second into the lens material, resulting in liquefaction. There is no heat, and the introduction of the cannula is a soft plastic tip. Advantage is no heat at the wound, no wound burn, less endothelial cell disruption, less risk of posterior capsule disruption. Disadvantage is expensive and too slow for hard cataract. I'm sorry, this chart, I have purposely put this slide because this is a teaching session where I want to show the students that we know that you know the answer, but you cannot write everything in 10 minutes or 12 minutes. You have 10 questions and you have 3 hours time. So approximately 10 to 15 minutes per question it goes. The best way is to answer in these like this in flow charts. So you have a patient with cataract, how you evaluate the system, then what investigations you can do. You have to avoid intraocular pressure, rise in the intraocular pressure. You have to ensure that the patient is immobile. Then you need to select what kind of anesthesia technique are you going to select, whether it's topical, regional block, then with monitored care. If you're giving a general anesthesia, then intubation with fast-track drugs. Extubation should be smooth without coughing, or and care should be taken that they don't have post-op vomiting and nausea. So, you know, when you're writing the answer, therefore, most of my slides had pictures also of the blocks. So if you have, you can write your answer in flow charts and diagrams. It saves a lot of time, and the examiner knows that you know your subject. You cannot write everything in that 10 to 12 minutes time per question. So in conclusion, cataract surgery in elderly population is becoming safer, faster with use of small self-healing incision sites and foldable lens technology, and increasing trend towards utilizing topical anesthesia. Decision on the type of anesthesia to be used depend largely on the patient, the expected duration of operation, and preference of the surgeon. General anesthesia may be preserved for only special circumstances. Careful preoperative evaluation, selecting the anesthetic technique properly and with care, along with increasing knowledge and skill, may decrease peri and postoperative complication and improve patient experience. And the success of intervention may also be increased by optimizing collaboration between the surgical and anesthesia team. Finally, it is a teamwork. So I have picked up the questions which are repeatedly asked in theory on cataract or ophthalmic anesthesia. So this is a slide which is showing that what are the frequently asked questions. Describe peribulbar block, indication, technique, and complications. I think we have covered that. Merits and demerits of retrobulbar block versus peribulbar block. Anesthesia for intraocular surgery. Oculocardiac reflex. Describe different anesthesia technique practice for cataract surgery and their complications. What is monitored care anesthesia? Describe the technique in a 80-year-old patient with ischemic heart disease scheduled for cataract surgery. Thank you.
I think Dr. Prerna Gomes has covered most of the questions which have been asked in the DNB papers, and she's also in fact displayed all the questions. Dr. Prerna, just one question. When you have these these pediatric patients who undergo this strabismus surgery and which are more prone for oculocardiac reflex, I did read somewhere, though I don't do ophthalmic at all, but they said that infiltrating the recti muscle, the medial rectus, it does help when you have this oculocardia. Am I right in this?
Yeah, yes, I had in my slide also I did mention that if you give a local anesthesia, it inhibits the afferent pathway and it prevents the oculocardiac reflex. Absolutely right.
Dr. Prerna, we are very fortunate to have with us very senior madams with us, Dr. Alka Halbe, Dr. Nayak madam, Dr. Dhaigude madam, and Falguni also with a lot of her experiences from Nair Hospital with Opthal. I think I'll just leave the forum open for them to ask any questions or discuss something if they want to, and later on if the residents have any questions, I think they are feel free to ask, madam, please.
Hello, Prerna. It was very nice, very comprehensive, and what I liked was you have added questions. So that is
Ye-
what DNB students are looking for. So that is one thing good. The only thing I wanted to ask, in a pediatric patients, about those. Of course, now it must be less glaucoma and those buccal mass surgeries, na? So what do you, is the same thing which is the standard anesthesia technique, or you do
Yes,
patient?
yes, ma'am. Same anesthesia technique,
Same, the standard one. Nothing
standard one.
before that, like giving something like we used to give in those days in Nair. I'm talking of long ago, about 15, 20 years ago. We used to give either mannitol or glycerol, something like that, to reduce the pressure and then induce the patient. For a buccal mossa, I'm talking of.
Yes, ma'am. If the normally the surgeon tells us whether to give mannitol or not, madam. If it is required, then we give it
Acha,
preoperatively also before the induction of the anesthesia.
right, right. So, but I think nowadays we hardly see such patients. No?
And we don't use choline at all, madam. We don't
Ah,
use choline at all.
that's true. That's true.
Yeah.
Anything, any comment? Daigude madam, Lalita madam.
You can hear me, Kalpana?
Yes, madam.
Yeah, Dr. Gomes, I've sent you a message. Very nice and very lucid lecture. You have covered everything. I just want to make one comment that nowadays we don't give retrobulbar block. More in the 80s and 90s, we were giving. So if you use a long needle, it pierces the optic nerve sheath, and the local anesthetic agent is directly deposited on the brainstem. So that gives rise to basal anesthesia or brainstem anesthesia. Actually, I have reported one case in Singapore Journal, and the patient first loses consciousness and then respiratory arrest and then cardiac arrest. This is exactly how it actually, if you know, we can prevent cardiac arrest. Immediately you can intubate the patient and prevent cardiac arrest. If you are watching the patient and the patient starts losing consciousness, that means patient is having there is an onset of brainstem anesthesia. That's one thing I want to tell. And if the patients are on dabigatran, and now we are nowadays we are getting the antidote, Praxban or Idarucizumab. That
Okay.
antidote is available now.
Okay.
Or
Okay.
direct acting, direct thrombin acting anticoagulant. But it was a nice lecture, very nice lecture, very lucid, and I'm sure postgraduates must have enjoyed it really. Very nice.
Thank you, ma'am. Thank you. Madam, about the retrobulbar block, therefore I said that it is hardly in use. One of the latest literature. Yeah. Yeah. No, nobody uses now.
Yeah, especially those days. I remember when I went to Sion Hospital in '87, I was shocked. They used to keep the rubber ball sort of thing on the eye, to have a pressure, even pressure or something like that. So once or twice we did rescue the patient about to arrest the patient, so then they stopped and they started peri-orbital block. And of course now all those things are all historical.
Yes, ma'am. Therefore, for the students, they must know, because this block caused a lot of complications, and it has been asked repeatedly been asked for the theory paper, ma'am.
Yeah.
Retrobulbar block. Therefore, I put the diagram also so that they understand what it is.
Yes. Another thing, this ocular cardiac reflex. V1 is very notorious in giving ocular cardiac. Cardiac, trigeminal cardiac or ocular cardiac. More towards periphery, you come to trigeminal branch V1. There is a chance of ocular cardiac reflex. So pre-operative medication with anticholinergic can prevent it. If you have to give anesthesia, especially in children and all, to prevent whatever little chances of cardiac arrest are there, ocular cardiac arrest, you can prevent it by giving those days we were giving atropine, now of course glycopyrrolate is there.
Yes, ma'am.
That can break the cycle of ocular cardiac reflex.
Yes.
vagulitis. Agree, Alka?
Yeah.
Kalpana, I have one very interesting case we had in Nair Hospital, but I think I will, in the end, it will take, because I have prepared a small pictures I have got. I got it from 2004 ka pictures, I found them. So at the end of the, let Falguni also finish. If there is a time, then I will show it.
Ma'am, if you can show it now, I can see.
Okay. It is a charge syndrome, CHARG. Madam, if you remember that this patient had really, one sec, I will, how do I show it, Kalpana?
I have stopped sharing.
Yeah,
I stopped sharing.
You will stop sharing and I will make you the co-host.
Okay.
I have stopped sharing, huh?
Yeah, so madam, I have made you the co-host now.
Share screen, I should click.
Now you just do, yeah, click.
Share screen, but I don't see my desktop. How do I go to my desktop? Shall I click share here?
Yeah, madam, the green arrow, just press it. Can you see a green arrow which saying share screen?
Yes, I have pressed it. Then there is a corner, there is a share. I'll click that.
Click that, yeah.
Yeah, it is coming.
Yeah, we
One
can
second.
see.
I think now one junior has to take lecture for us, how to go on, how to share and everything. Now one PG can take lecture for all these senior citizens.
What is in my name here? I missed it, madam.
Nice. You are not senior citizen
So
yet.
this is a Charges syndrome. There are 6 things in this. Coloboma of the eye. Then there is a heart disease of various kind. It can be anything, ASD, VSD, PDA. Atresia of the choanae, which is the one which is we have to be most careful. Then there is a retarded growth. There can be mental retardation. There can be various CNS anomalies. Then there could be genital. Usually there is a undescended testis and it can be hypospadias. And there are various kinds of ear anomalies. Now this 4 out of 6 characteristics must be present to label as a Charges syndrome. Falguni, do you remember this case? And this, see, this is how it is. This is one of the anomaly. This is the simplest thing. You can see the pupil like this because of the shape of the iris. It can be various. If you go on the net, your students can find all that. So coloboma is the eye abnormality that occurs before the birth, and colobomas are missing pieces of the tissues in the structure that is around the eye. And Charges syndrome is due to abnormality of the CHD7 gene located on the chromosome 7. And it is very rare, but incidence of 0.1 to 1.5 in 10,000 live births. Now, this is the case I'm talking of. This patient we had when he was, this is a 2004, and I think he was 11 years old. But when he came to us, he was only 6 or 7 years old for an eye surgery on the right eye. And in a pre-op, they totally missed his choanal atresia. Nobody noticed the choanal atresia, and patient was induced, and they could not ventilate the patient because the tongue was little large and the mouth was smaller than this, and nothing. And luckily, it was cooling, and they had given a good pre-oxygenation. That is how patient, I think, survived that period and came out. And then post-operatively, when we saw, he had a total choanal atresia. And then luckily he recovered. There was no neurological deficit and patient was discharged. And then he came in 2004 for a undescended testis, which we see in 2004, we did not have any special laryngoscope or nothing we had, We just had classical laryngeal mask. So what I did was, we did on a undescended testis, we managed on I gave epidural and we managed with the LMA. But we could not intubate this patient. It was very, very difficult. See, this is how it is. See, you can see now here this, and you can see a scar over here. And see, there is no muscle tone at all, this patient. Now the choanal atresia is like this. If you see now, afterward when we saw you can see a whitish thing. The choanal atresia is defined as congenital stenosis of the posterior apertures, and in the absence of communication between the posterior nasal cavity and nasopharynx. literally nothing on how catheter also goes. It's a absolutely stone-like thing, and the patient can get choked up. So after that, I learned a lesson. This is how it looks, you know. Nasal passages are narrowed or blocked either by soft tissues or by bone. So after that, I learned a lesson for any small child. Unless you see the nasal patency, should not be taken on the table. That's the lesson I learned from this, and I want all the students to do it. And for especially for ophthalmic anesthesia, how it is relevant, because there's so many syndromic patients come for this, you know. So this it was lucky that that patient survived that time. Okay, and this kind of patient our students will never see. These patients come only to general hospitals. So I thought I'd take this opportunity and show it to them.
Yeah, but Alka, but why intubation was difficult? I can understand it. When you are ventilating a baby, when you should keep, that's why I expect a baby to have a coronal atresia or blocked nostrils. So you keep the mouth open and ventilate, or you know. But in this case, is there any problem for intubation also? Why intubation was
Madam, तुमचं नीट ऐकूच येत नाही. I really cannot hear.
Madam is asking, why should intubation be difficult in such a patient?
He had other features also, no? That the jaw was very narrow, and I do not know the hypoplastic, I think the area in the pharynx.
Okay.
That is it. We postoperatively we took a good bite, tongue stitch, and we maintained him on the side. Yeah.
Okay.
Madam, the first time when you intubated him on scoline.
Pardon?
The first time when you intubated him.
Yeah, it was on the scoline. They were attempting on scoline, you know, that time.
Were they not successful in intubating?
No, they could not ventilate. No, first he ventilated nahi kar sakte, so what can they do? They were very scared that time. They attempted putting a airway, but see, once it was a tension sets in, probably they could not do it.
Okay.
That's the reason.
Okay.
Okay, thank you.
Thank you, ma'am. Thank you so much. You really come up with certain small pearls of wisdom for us students.
Thank you.
And with this, I think Dr. Prerna has some other commitment at 4 o'clock. So, Dr. Prerna, I'd like to thank you on behalf of all of us here. It's very kind of you, and please keep joining us, and please share whatever lecture series you can take for our students, which will help them a lot. I thank you. I immensely thank you for this afternoon time that you have given us.
Thank you so much for having me, Kalpana. And definitely, I will ask my department also, my colleagues to put in the lectures, whatever you want. And we can make it a very interesting program with the seniors, because the kind of seniors experience they have, you know, we are not able to see what just now what Madam has shown. Yes. So most of us are working in a corporate setup. So it's difficult to have such cases. So thank you, madams, for on a Sunday afternoon, you spend time to be with us. And
Prerna, they've been there throughout the lockdown, yes. All the madams, and I think it's because of them that this program is running so well, because they put in such effort. And there are small, tips and tricks that they give us. I really wonder if our residents can really imagine how I feel myself so blessed to be learning so much. And I'm sure they do also.
Thank you, everyone. Definitely. Thank you, everyone.
Thanks, Prerna. Yeah.
Thank you. Thanks, sir.
Thank you, ma'am.
So with this, we move on to our next topic, which is dental anesthesia. And for this, we have somebody who's always been a part of our DNB clinical meeting series. And she doesn't need much of an introduction. That is Dr. Falguni Shah, who's a senior consultant at Lilawati Hospital. She was an ex-associate professor at Nair Hospital, and she's also an accredited instructor for the American Heart Association life support programs. She has authored and co-authored many of her books, and one of her recent book, which she has been an editor of, is Neuroanesthesia Practical Tips. And she has a lot of interest in teaching regional as well as pediatric anesthesia and emergency medicine, of course. And her passion for teaching is well seen over here, because here she is again on a Sunday afternoon, like many afternoons she has been with us, and to clarify the topic that she's going to talk. And today is going to be dental anesthesia. With this, I make you the co-host. 1 minute, sorry.
Yeah, sure. Thank you so much, Kalpana, for the kind words. I think you are one of the encouraging factors for the whole teaching program, because you have been, persistently conducting and kind of contacting all of us from time to time. And I really appreciate, and of course,
Falguni,
all the team.
I just hope the students don't have my photo on the wall and they're not hitting me with the thing.
No, then they wouldn't be here on Sunday afternoons. I'm sure they are not. Uh, and of course, all our senior madams, who have been like pillar of support to all of us. So, can I share my screen now?
You are the co-host now.
Yeah. Is it seen well? And am I audible as well?
Yeah.
Thank you.
Yes, Falguni, you're audible.
All right. Good evening, everybody. My topic for today is anesthesia for dental surgeries. At the outset, I will just say that it's that way huge topic. So I have done a brief overview, keeping in mind the clinical practice as well as the questions that are asked in your theory, as well as some short cases that are put up for your practical exam. So I have tried to cover salient points from keeping in mind these factors. Just a disclaimer that all the patients who are shown in my presentation, the informed consent was taken to share their information for academic purpose. And my special thanks to Madam Halbe and Dr. Vandana Lahiri for sharing some of their important case report material for my today's presentation. So thank you, Madam. Alka Madam is here, so I take this opportunity to thank her for that. If you go back to the history, the first general anesthesia for dental extraction was given way back in 1844 by Horace Wells, and he had used nitrous oxide that time. However, in 1846, one of his pupils, W.T.G. Morton, successfully demonstrated use of ether to facilitate the dental extraction. And from there on, over so many years, dental anesthesia has progressed from general anesthesia, both intravenous and inhalation, to local anesthesia, to sedation and conscious sedation, and combination of all of these during our clinical practice. If we see the general anesthesia or anesthesia and dentistry for various surgical procedures, we see them on dental chair or dental office anesthesia. We see them for daycare anesthesia in our minor operating rooms, where the procedure is usually less than 1 hour with not much anticipated peri-op complications with patients who are belonging to ASA 1 or 2 category. Or sometimes more complex procedures, especially the maxillofacial ones, or patients with a lot of comorbidities, pacemakers, heart blocks, etc., etc. Sometimes they are indoor patients, and we admit them, keep them overnight for observation, and conduct these surgeries. So these are the setups where we are likely to see the dental anesthesia practices. This is Mr. Morton, who was the first one to demonstrate successful anesthesia. And as I said, we can have dental patients either in the dental office on dental chair or in our regular ORs for various short as well as complex procedures. We can have pediatric cases where many a times we are required for successful conduct of the procedures, and we are mainly required for many maxillofacial surgeries by maxillofacial surgeons, as the complex airway management is required during these cases. So if we see the main purpose and why it's challenging is that the surgeons need free access to the surgical field, obviously. However, they keep moving the head and the neck, they push the mandible down backwards, and they displace the tongue backwards to have their surgical access. They also put various instruments, packs, drill, irrigation, cannulas, suction apparatus, etc. in the mouth. And we as anesthetists, We want free access to the head and neck because we want to oxygenate the patient well. We want to ventilate them. We want to prevent aspiration by sucking out blood, saliva, the debris, the tooth fragments, etc. And therefore, we want the free access as well. And while doing that, we end up obstructing the surgical field. So it's a very, tug of war kind of a situation in many of the dental procedures where both surgical colleagues and we as anesthesiologists are sharing the field. Coming to and that's why it's very, very challenging and a good teamwork is required. Coming to the dental chair anesthetic implications. Now, this is one of the commonest questions asked in your DNB theory papers. Now, dental chair usually are OPD procedures. We come across all age groups in this practice. Position is, of course, in the dental chair. We are sharing the airway. There's a lot of anxiety and pain involved. So many of the patients really experience a lot of stress. And many of the procedures are done under local anesthesia. However, even if local anesthesia is used and we are just present for monitored care and anesthesia care or minimal sedation, one need to make sure that we have selected the patients very carefully, optimize their physical status, even if it is under local anesthesia. Strength of the local anesthetic solution, which is used by the dentists, have to be kept in mind. One has to be very vigilant for that. And the total dose that they use adrenalized solution most of the times. We may have elderly people with ischemic heart disease, people on multiple drugs with other comorbidities. So one needs to keep in mind all these. They add, as I said, they add adrenaline as well. And keep in mind a possibility of LA toxicity, especially if there's an accident intravascular injection. Now, what are the factors that one needs to keep in mind when you're anesthetizing a patient sitting on a dental chair? It can affect circulation because of the very position of the patient, airway because the surgeon's working there, patient is in the sitting position, and of course there are certain respiratory implications as well. Now, what would be the ideal dental chair be? So the ideal dental chair should have ability for both horizontal as well as head down position in case of emergency. It should have a manual release during power failure. It should have adjustable headrest, and it should also have an adjustable armrests. Now, traditionally, it was done in the upright sitting position in the dental chair where your oral cavity, the mandible would be like this. And when the patient opens, the mandible lies more or less perpendicular to the floor. And if you make the newer chairs can be even made almost supine with the surgeon sitting at the head end, where if you open the mouth, the mandible lies almost parallel to the floor. And the very ideal position would be to have a semi-supine position. So you have a head slightly extended, mandible horizontal and parallel to the floor when mouth is open. Now you may have to give sedation or anesthesia, in dental chair. Now, where are we required when it is children? Some of them are really anxious. They need to be sedated and at times even given general anesthesia. Uncooperative adults, mentally subnormal patients, patients with movement disorders, patients who have severe allergy to local anesthetic, you are called for standby and resuscitation, and some complex surgical procedures which take longer time, or like say a badly impacted wisdom tooth, one may have to give sedation or general anesthesia even in dental chair in their office. So the various methods performed apart from monitored anesthesia care are conscious sedation, deep sedation, or general anesthesia, as I said. Now, what is conscious sedation? It's a controlled, pharmacologically induced, minimally depressed level of consciousness that retains the patient's ability to maintain the patent airway independently and continuously and respond appropriately to the physical or the verbal commands. Now, every word is important. So students, that what do you exactly mean by conscious sedation? So it is minimally depressed level of consciousness. It retains patient's ability to maintain the patent airway reflexes independently, and they do respond appropriately to the physical and verbal commands. These are the various nasal masks that are used commonly on the dental chair. So it doesn't obstruct the surgical access, as well as you can administer various inhalational gases and oxygen through that. We will come a bit in detail about these masks in a while. The contraindications would be patients who have inadequate nasal breathing. So obviously you can't give oxygen or other agents to the nasal mask. Patients who are deaf, because then they are not amenable to your, suggestions during that conscious sedation, and it may be difficult to control their, mouth opening, etc. Improperly fitting masks due to facial abnormalities and severe respiratory diseases. It's better to avoid conscious sedation with inhalational supplementation. In those cases, maybe securing the airway completely and giving general anesthesia may be a safer option. Now, then a stage of deeper sedation. It is controlled, pharmacologically induced state of depressed level of consciousness from which the patient is not easily arousable, and it is accompanied by partial loss of protective reflexes as well, including ability to maintain a patent airway independently. And patient may or may not respond purposefully to the physical stimulation or the verbal commands. So now this deep sedation may be not so desirable in dental practice because it's a oral cavity surgery or the oral cavity procedures, and we are always worried about aspiration of the secretions, blood, the dental fragments, the cement or the composite that they've used, etc. So one has to avoid going into these deeper planes of sedation. And then, of course, there is general anesthesia, which is like complete reversible state of unconsciousness with hypnosis, reflex suppression, analgesia, and complete muscle relaxation if required. So we have various sedation techniques in dental practice, either oral, rectal, intramuscular, submucosal, intranasal. This will be non-titratable. That means one-time dose is given, you cannot withdraw or titrate further. And titratable would be the inhalational and the intravenous sedation. And many a times we use combination of both. The respiratory complications that one needs to keep in mind when you are anesthetizing or sedating a patient on the dental chair is because of the position, pads, the rubber dams that they used, you may have airway obstruction, respiratory depression because of the drugs that we are using, aspiration of the secretions, dental debris, and sometimes even trickle of saliva can cause laryngospasm, and the various sedatives may at times in sensitive individuals give rise to hypoxia and hypocapnia. Cardiovascular, hypotension, bradycardia, dysarrhythmias, fainting, vasovagal or vasodepressor syncope, orthostatic hypotension because of the sitting position, and in rare cases, one may have cardiac standstill. Vasovagal shock or syncope is one of the most common, scenario when it comes to dental practice. I remember when we used to go to the dental hospital, Naya Dental Hospital as anesthetists, and we would be, a team of 4 or 5 anesthetists working right from professor to the first year resident. And in a day, we would at least get 4 to 5 calls from entire hospital that the patient has suddenly fainted in the dental chair and the anesthetist is required to kind of, assist. And we would run from one floor to other, from the OT to the dental offices and kind of, give supportive measures till this vasovagal attack is taken care of. I think Halbe madam would agree to that. That is one of the commonest calls that we would get in from various departments in dental hospital. The various factors are the adult females are more prone. The commonest age group is younger age group, 16 to 35. Hypoglycemia, hunger, exhaustion, in general, poor physical condition, hot, humid, crowded environment, and of course, upright and standing position for long. There are psychological factors which may predispose them to the vasovagal attack. They are fright, anxiety, stress, pain, sight of blood instruments sometimes itself can activate vagal response. Pediatric, very small babies or children usually don't show vasovagal attack because they do not hide fear, it is said, and therefore they usually don't experience vasovagal attack. Now, how usually the patient presents? There are various phases when it comes to syncopal attack. Now, pre-syncope patients usually have feeling of warmth. They suddenly become white or pale, heavily perspire. They complain that I'm feeling bad, or I'm not feeling all right, or I'm feeling as if I will pass out. Nausea may be present. However, at this stage, the BP and heart rate may be normal. And later, as this progresses, the patient may have, may start yawning because of hypoxia, cold, clammy hands and feet. They may complain of blackouts and visual disturbances, dizziness, they may hyperpnea, and pupillary dilatation. Then when they advance to the next stage, phase 2 of syncope, there will be loss of consciousness, bradycardia, hypotension, generalized hypotonia and muscle relaxation, and airway obstruction. And phase 3, that is post-syncope or the recovery phases, patient will return to consciousness. The heart rate and BP will start normalizing. There may be some pallor, or patient may be still slightly cold, but the patient may have nausea, weakness, sweating, little confusion, disorientation, which may persist for a little longer time. The differential diagnosis, when you get a call for any patient who's become unconscious in the dental chair, apart from your syncopal attack or vasovagal attack, which is one of the commonest ones, should be undue stress, drug-induced epilepsy, orthostatic hypotension, hypoglycemia, or some allergic reaction. The other rare ones are acute MI, cerebrovascular accidents, hyperglycemia, hyperventilation syndrome, or acute adrenal insufficiency. These are the rare ones. How do you manage that? Stop the procedure at once. Make the patient supine with slightly elevated feet so that the venous return is enhanced. Attach whatever monitors you have at that point of time, the pulse ox, the ECG, the blood pressure. Make sure that the airway is patent. If patient is breathing well, turn them to recovery position so that, the tongue fall is prevented. Give oxygen, artificial ventilation if required, if patient is not adequately breathing. Maintain circulation, measure BP, IV fluids, anticholinergic agents, and vasopressors like ephedrine, Prerna, etc. may be required to kind of normalize the blood pressure. CPR if warranted, ICU admission if again patient has had severe syncope. Try to determine the etiology and treat that. Like say if it's hypoglycemia, make sure that the patient gets some glucose, water, glucose powder so that, the patient can be, kind of sent home as quickly as possible. As far as possible, don't do further dental treatment on that day for at least next 1 day, and then patient to be sent home with an escort. Don't leave the patient alone. Many times dental patients come alone to the dental office, which may be kind of, a little bit of problem when it comes to, such vasovagal attacks. So make sure you call the relative or a responsible adult who can accompany the patient. Now, the other area where we really are called for dental anesthesia are the pediatric patients or the pediatric suite. So we can have their patients ranging of all age groups, all pediatric age groups, that is 1 month to 12 years. We may have to give MAC, we may have to give sedation or full-fledged general anesthesia. Usually we are called for multiple extractions, restoration, or the composite work. And the duration of such procedures can be anywhere from 15 minutes to 3 hours. The common group of these children are either mentally retarded ones, or they may have some rare syndromes associated with mental retardation, cerebral palsy, Down syndrome, congenital heart diseases, other medical diseases, physically challenged or handicapped children, or some highly uncooperative, though otherwise normal children. These are the situations where, we generally need to attend these patients and provide anesthesia services for the dental procedure. Coming to conscious sedation, apart from the drugs like say chloral hydrate or midazolam, ketamine, a little bit of propofol, etc., the most common agent that is used for conscious sedation in dental practice is nitrous oxide in the form of Entanox, that is oxygen and nitrous oxide mixture. And this is one of the short note asked in your DMB paper as well. Nitrous oxide is immensely popular sedative inhalational agent. It's obviously very popular because of its quick induction and fast emergence properties. It is relatively safe when it comes to daycare anesthesia, provides excellent analgesia, amnesia, and anxiolysis. And there are no major side effects when we use it in 30 to 70%, along with, 70 to 30% of oxygen, with or without the other sedatives. However, the more the concentration of nitrous oxide, one may see some amount of nausea, vomiting, clenching of jaw, uncoordinated movements, and loss of verbal contact at times. They may not be amenable to commands. And therefore, it is prudent to restrict your use to up to 50% or less of nitrous oxide along with oxygen combination. Now, we do get Enternox delivery machines. This is one of the biometrics company flow meter, where you can see there is a flow meter for nitrous oxide and oxygen. Here the circuit is attached, the reservoir bag is attached here, and you can titrate your oxygen nitrous concentration, which is delivered through the nasal mask applied on the child's face, and you can achieve good conscious sedation and analgesia by using this system. This is the double mask scavenger breathing system, which is very popularly used in pediatric dental setups. As you can see, it is a coaxial tubing, and this is what is called as the double mask scavenging. It's a nasal mask which are two masks. The inner one is called the nasal hood, where the inspiratory gases are flowing through one of the tubings through the circuit, and the outer mask, as you can see, is called the liner. So the gap between the liner and the inner hood is filled with your exhaled gases, because there are flap valves here. And these exhaled gases can be sucked through the scavenging system by these separate outlets. So this helps you to prevent theater pollution, or at least to minimize the theater pollution when you're using nasal Enternox. So this is one of the popular assembly of circuit used in many dental setups. And as you can see, there's a flap valve. There are two nasal masks, the inner hood and the outer liner, which is connected to the scavenging tube. This is how it works, what I already explained in the previous slide. Now, there are some fancy pediatric nasal masks available, which are single use. They are scented with, pleasant aromas, so the children like them. They're convenient, safe. They're single use, so no need to sterilize, autoclave, and obviously the risk of infection transmission also is minimized. They are packed with colorful cartoon stickers to attract the children, and they are very soft, latex free, and X-ray compatible as well, importantly, because sometimes they do take dental X-rays intra-op. So they are the nice ones, and usually children are comfortable with that. Then you have transparent nasal masks available called the slout nasal masks, which are also pretty popular in dental practice, pediatric dental practice, and keeps your oral cavity completely accessible to the surgeons. And the child is given, colored glasses, or sometimes you have those fancy, what they call it, I think they call it video glasses or something, where, the children are seeing some video through those glasses and getting distracted while the procedure is being conducted with minimal Enternox conscious sedation. So this is the slout mask, as I told you, which is then connected to your circuit, which is coaxial, and one is for scavenging, one is for the fresh gas flow. Now, preoperatively, wherever you are anesthetizing these patients, whether it's dental office, whether it's your minor OT or your regular OR, detailed examination and optimization is must. Make sure they are adequately fasting according to ASA and ISA guidelines. If certain children, like say patients with cerebral palsy or certain congenital syndromes, maybe they need to be fasted a little longer, because they are known to have little delayed gastric emptying and loss of lower sphincter tone, like say Down syndrome, etc. So these points need to be kept in mind. instruct them to wear loose-fitting clothes, especially when you're doing them in the dental office, when you're going to do the procedure and anesthesia in their own civil clothes, and make sure that a responsible escort is accompanying and going to take the child back home. Till mid-90s, only clinical monitoring was done along with pulse, BP, respiration. However, now we recommend that you need to have standard anesthesia monitoring like any other surgical procedure, even for these dental anesthesia practices. And so you need to have SpO2, ECG, TCO2. And if you're going to give full general anesthesia, actually, even if you're going to give local anesthesia, because you're going to use adrenaline lignocaine for almost all of them, it is good to have a defibrillator standby as well. Now, this was one of our pediatric dental office when I used to work in Nair Hospital, where we used to anesthetize children on this dental chair. We had, a complete Boyle's machine there along with a multi-para monitor. We had a defibrillator here. I'm sorry, it's covered, but you can't see, but we also used to have a defibrillator there, a good working suction machine exclusively for anesthetists here. There is a separate suction attached to the dental chair. And what we had done is we had a special supine board, device which we would put by making the chair completely horizontal. And we would kind of almost convert the dental chair into an OT table to make it very comfortable to give full general anesthesia to children. So this was the setup. Like this picture is, I think, way back in 2003-4, somewhere in that time, and we had a completely well-equipped pediatric dental outpatient office where we used to do children under anesthesia. So as you can see, we used to intubate them through the nasal tube whenever needed, when a prolonged anesthesia was required. And that would be done comfortably by making the chair horizontal and putting the board over it, a supine board. Conventional GA was given. We, in supine position, pre-medicate them with the anti-silagogue, good sedative, analgesic, induce with propofol or pentothal, scoline or atrofurium for intubation, and maintain them with oxygen nitrous or air oxygen, CO, and atrofurium. This is what the standard practice followed usually is. This is another child, and as you can see, at the end of the surgery, we would extubate them from the nasal system, conscious. We usually used to give oral midazolam or ketamine to these children before taking them in, secure the IV line, give some inhalation, intubate, and then extubate when they are completely awake. Post-operatively, make sure that you monitor all the vital parameters for adequate time, maybe for 45 minutes to 1 hour, till they are completely awake and out of effect of all your anesthetic. Maintain their level of consciousness and observe them. Recovery position may be required, oxygen supplementation may be required in the recovery area. They should be able to maintain a clear airway by coughing or swallowing adequately in case there are some secretion or minor trickle of blood coming out from the raw areas, and follow the recovery criteria. Child should be able to sit, stand, walk without support before you discharge. There should not be any nausea, vomiting after drinking water or some, soft diet. Usually we used to give them vanilla ice cream before discharging them. And if they're comfortable eating that, no nausea, no vomiting, they passed urine, we would send them home. So usually it would be about 3 hours to 4 hours after the anesthetic. The other area which we are called for is various maxillofacial surgical procedures. And here sometimes the anesthetic job is really intense and difficult because we involve all complex maxillofacial deformities or difficult airway cases. So let's see the areas where we can be face the challenge for the cases. The usual pathologies, the common ones are submucous fibrosis, TM ankylosis, receding or small mandibles and reconstructive procedures for that, advancement of mandible, etc. Or they can have tumors in maxilla, mandible, gums, palate, or sometimes the abscesses because of the infection, submandibular or Ludwig's angina. They may do various procedures for these pathologies like osteotomies, advancements, fixation of fractures, release of SMF or TM ankylosis, hemimandibulectomies, and various palatal surgeries. And all these cases may pose difficult airway challenges for us as the anesthesiologist. SMF, TM ankylosis, etc. are kept as short cases many a times during the MD exam, practical exam. So we need to kind of have idea about how to manage them and what they can present with. So here, these are the cases in whom the airway is maintained when they are awake by compensating the deformity with muscular efforts. However, partial or complete obstruction can happen once you sedate or give general anesthesia to these children, and therefore no GA or muzzle relaxants to these patients unless the airway is secured. Remember that, patients with SMF, TM ankylosis, microapnea, retroapnea, they come for various advancement surgeries. During preoperative history, the important points to be noted is any history of snoring, sleep apnea. Even small children with TM ankylosis can have severe sleep apnea. I had one case who was about 5-year-old when I was in maxillofacial department at Nair Hospital, had congenital TM ankylosis. Patient, for some reason, was not treated till child was 4 or 5 years old, and then started having problem breathing, and then was referred to the tertiary center at Nair, and subsequently, I think by the time he was operated, he was nearly 6 years old. And when sleep studies were done in him, he had severe sleep apnea with oxygen saturation dropping to almost 50-55% at the least during the night sleep. And when we did the baseline ABG, even his baseline CO2 was somewhere in 50s at that time. So these are the patients which are going to be extremely sensitive to all your anesthetic drugs, and one needs to be very, very careful while anesthetizing, and even more so when we are extubating these children or these patients in general. It may be an adult patient. Any history of dyspnea, any hoarseness, stridor, and any important point during the past anesthetic management. So these are the points to be, apart from your regular preoperative checkup, these are the points to be kept in mind. Now, what problems they can have, or what do you need to look for, is patients group at risk is patients who are obese with short neck, elderlies with limited joint movements, patients with protruding teeth, or with neck masses. The useful tests that we need to see for the airway assessment, obviously the mouth opening, malam patti grading, mandibular space, head and neck movements, and investigation like X-ray, neck, and CT scan can help you assess the patency of the airway and the airway passages well to plan your anesthesia airway management for these major surgical procedures. And as discussed during even the previous, talk, that always examine nasal patency, especially in all these cases, because it is nasal intubation which is going to be required in most cases by the surgical team. So picking up the patients who maintain their airway while awake by compensating their deformity with muscular effort. How do you pick them up? As I said, there are various methods on examination. If your men-to-higher distance is less than 3 centimeters, that is this distance. If your thyro-mental distance is less than 6 centimeters, and if your horizontal length of the mandible is less than 9 centimeters, then beware that these patients may give you difficulty in laryngoscopy and visualization of the glottic opening. Any patient with congenital anomaly like receding mandible, microapnea, trichocolons, Pierre-Robins, or the other maxilla and mandibular deformity, one may have problem during laryngoscopy and intubation. Patients with short, thick neck Macroglossia neck masses, as I said earlier, can also pose challenges for airway management. A bit about head and neck movement. You ask the patient to flex completely, ask the patient to extend, and then see for the neck movement. That's on gross. But if you want to quantitatively assess that, mark a plane from the lower border of the upper incisor, ask the patient to extend completely, mark a plane again, and the angle that is formed between the first plane and the second plane, if it is 35-degree or more, then by and large the neck movements are normal and you are unlikely to face problem during positioning for intubation and alignment of all your oropharyngeal, pharyngolaryngeal, and your uh, glottic inlet axis. Pre-oxygenate well. Remember, these patients may take a little longer for intubation, so make sure that you've given them 100% oxygen for minimum 3 to 5 minutes. Now, the normal sequence of event is you induce with induction agent, then intubate, maintain, monitor, reverse and extubate, and post-operative monitoring, of course. Now, in these patients, sometimes this 2 steps are many a times, not sometimes, many a times reverse. That is, you intubate them awake when they're still awake and then induce the anesthesia. And you may or may not extubate them at the end of the surgery, depending on what surgery they've undergone, how much edema is present post-op, how much was the airway obstruction pre-op, etc. Now, the various methods for awake patients, that is awake airway securing, are the direct laryngoscopy and intubation. This is all, of course, after giving airway local anesthesia. That is, although airway is anesthetized by local anesthetic, by your nebulizations and blocks, etc. I'm not going to go into those details because it's not possible to complete that otherwise. So local airway anesthesia, and then either do a direct laryngoscopy and intubate, do a blind nasal intubation with the aid of your capnometer and the sound of the airway blast. You can do retrograde intubation in certain cases. We will be just seeing some of them in a while. And of course, the gold standard is your fiber optic bronchoscope guided intubation. However, even today in some of the setups, the fiber optic scope may or may not be easily available to all the anesthesiologists. And sometimes even the skill is not adequate. Now, if all these fails in these difficult airway cases, of course, one has to be ready for front of neck access, either in the form of cricothyrotomy or tracheostomy. In your pre-med, make sure that you've given good antisyllagogue agents so that there are no secretions. This will also help your local anesthetic of the air, which you are giving for airway anesthesia, to work better. Give good analgesic drugs, antiemetics and antacids. If patient is on any drugs for the medical disorders, make sure they are continued, and no sedatives or tranquilizers to these patients before these airways secured, because sometimes, as I said, if they have obstructive sleep apnea, etc., they're extremely sensitive, and even minimal sedation can give rise to apnea, and you may have little crisis situation. Now, this is what all you keep ready when you have to perform awake intubations. I mean, this is one of our trolleys that we used to have in our maxillofacial department. As you can see, all the local anesthetic, the local anesthetic spray, the viscous, all this is to anesthetize the airway when they are awake. The various sizes of tubes. These tubes, as you can see, are the white ones here with a S-shaped preformed curve, were called Tehran tube, and they were used very often in our maxillofacial cases for blind awake intubation, where because of the curve, preformed curve. And if you can see here, the bevel is also antero-posterior. So when you pass it, it kind of, peaks up and enters the laryngeal inlet more easily than your usual beveled tube. So therefore, this was one of the commonest tubes used in our maxillofacial department for blind awake intubations. Those days, we even used to have red rubber tubes ready. These are the connectors with curved angle, so that when you connect the circuit here, it doesn't come in the surgical field. We always used to have jet ventilator with a, temporary cricothyrotomy set kind of, indigenously made ready in case of emergency. For retrograde intubation, if you can see here, we used to have, those days we used to use epidural catheters for retrograde intubation. So even that is ready. And this is, of course, tube exchanger, which was there. This is a cricothyrotomy set, which is kept ready. The nasal pack for the nasal cavity anesthesia. So as I said, you can have awake patient, you can have patient who can be anesthetized before securing airway, but these are the usual ones where the airway anatomy and patient's anatomy is normal, where you can anesthetize. But more often than not, these cases you would need awake intubations, and you can intubate them either with direct laryngoscopy after anesthetizing the airway, fiber optic laryngoscope, of course, the gold standard, the LMA, the various intubating devices, the blind nasal technique or the railroading. We'll see some of them now. And if all these fails, your front of neck access is there. Now, this is the patient for, I think, wisdom tooth extraction, where the airway anatomy was fairly normal, though he had a little prognathic mandible, but we had put LMA because the mouth opening was adequate. And the surgery was unilateral. So it was, we had slightly displaced the LMA and we could perform the wisdom tooth extraction, which was badly impacted pretty easily with the use of supraglottic airway. Of course, here you have to make sure, make sure that the suctioning is done completely. And we also used to put sometimes a kind of a pack over the laryngeal mask. The risk of aspiration was fairly low at that time. Of course, now with the second generation supraglottic airways, this was a little old one where we have put a classic LMA, but now with second generation, it's even more safer to use when it comes to such short maxillofacial procedures where the mouth opening is adequate. This is the nasal intubation, and as you can see, the curved connector which we all used to use, so the circuit goes away from the surgical field. Of course, you can use your North Pole RAE tubes in this case, or even flexometallic ones at times if you don't have the S-shaped curved connector. Coming to awake nasal intubations, of course, the fiber optic scope is a gold standard, as I said, provided you have all adequate sizes of scopes available and the expertise for the same is present. It's the most definitive way, most comfortable way to put it. The next is direct awake nasal intubation. Now, in these patients, what was done was you anesthetize the upper airway, like this is viscous gargles, as you can see. Then you give glossopharyngeal nerve block. This was a patient with submucous fibrosis with limited mouth opening, as you can see. It's hardly about 1.5 finger. And the glossopharyngeal nerve block was given. Then the tube was inserted from the nostril with good lubrication. Perform the laryngoscopy when patient is awake as gently as possible, and with the capno connector attached, guide your tube into the laryngeal inlet. And if the airway is anesthetized well, usually patient tolerates it pretty well. This can be done when patient has mouth opening, which is enough for at least introduction of the scope blade, where you can see the, if not complete glottic opening, at least you can see the posterior tongue and the pharynx, and you can guide your endotracheal tube well. Then the same patient, after the release of the SMF, as you can see, the mouth opening has improved. However, there is some amount of swelling around the lips, etc., because of all those retractors and all. We kept him intubated till he was completely awake, completely out of the effect of all the anesthetic agents, and then he was extubated post-operative. So post-operatively, patient can have tube in situ, or you can extubate on table, or you can extubate after a few hours in the recovery area, give humidified oxygen, monitor their vitals, give good analgesics, antiemetics, antacids. Steroids may be required to decrease the edema, and good head-up position also aids to improve venous return and decrease the edema of the oral structures. Coming to blind awake nasal intubations, as you can see here, this was also SMF patient with upper airway anesthesia being given, the gargles, the nasal cavity is packed with adrenalized lignocaine. Then we gave the superior laryngeal nerve block and the transtracheal nerve block to anesthetize the airway. This is the using the Tehran tube blindly. And as you can see here, the capno connector is attached so that you can, you can get good capnograph when your tube is in alignment with the glottic opening. With the amplitude of the capno, you can know whether your tube is going in the right direction or not. And of course, he is also listening to the blast sound to help him guide the tube. And once the tube is in, attach your connector. The oxygen also is being given to the T-piece continuously so that the oxygenation is also taken care of. You have the capno attached, and once the tube is the position of the tube is confirmed, then you anesthetize this patient. This is the same patient post-surgery. He had kept the tube for some time. Once he was completely awake, he was extubated. Adequate monitoring in the recovery area. Sometimes you may have to externally manipulate the larynx when you are doing the blind nasal by listening to the blast of the airway when patient is breathing spontaneously. So depending on the intensity of the blast, you either move the larynx to right or left slightly, and sometimes the tube goes in the larynx when the alignment is achieved. So that's the external manipulation. Now, this was a case which I was just talking about a while ago. Severe TM joint ankylosis, was not treated in time, developed severe deformity. Because of ankylosis, his mandible never grew to normal. He was about 6 years old when he came to us. And we had to anesthetize him. As you can see, mouth opening is barely half a finger with malaligned teeth, grossly hypoplastic mandible. And this was the patient who had history of severe snoring and history of sleep apnea preoperatively. So as you can see, it's ankylosis with micropnea. We anesthetized his airway, his nasal cavities, oral gargles were given, the nerve block was given. Thankfully, the child was pretty cooperative. He was, of course, counseled several times preoperatively over for, 2-3 days prior to the surgery. We almost became friends with him, because we used to see him every day for 3-4 days. And he really cooperated well for all these nerve blocks, and blind nasal intubation was performed in him as well. This child was not extubated post-op. He was kept with the tube in situ with oxygen supplementation. And if you can notice here, there's a tongue stitch taken because he had severe micropnea and the tongue would fall posteriorly and cause obstruction to his airway. So we had kept the tongue stitch that in case required, can just pull out his tongue. And the next day, he was extubated. The tongue stitch was still kept in place for another 24 hours. And then on the third day morning, when everything was okay, the tongue stitch was pulled out as well. Coming to retrograde intubation, now this was a case which was again post radiotherapy fibrosis of the oral cavity and inability to open the mouth. He had maxillectomy performed for the malignancy, following which he had taken radiotherapy and developed severe restricted mouth opening. If you can see, there's a gap here in his maxilla, for which earlier he used to use one obturator plate, but now the mouth opening had decreased so severely that he could not even use that plate for his, regular eating, etc. And this patient came for SMF, the release of these fibrotic bands. So it was obviously a very challenging task. You can see here, even the nasal cavity we felt was, slightly narrowed because of the radiation fibrosis. The opposite nostril was still slightly patent, so we decided to go through that. He was given airway anesthesia. Then an infant feeding tube was passed from his opposite nostril, retrieved through his oral cavity. Of course, this was the time when we didn't have the retrograde intubating set at that point. So we used to use these indigenously made infant feeding tubes and epidural sets for the retrograde intubation. So this infant feeding tube was passed, retrieved from the oral cavity and kept aside. Local anesthesia over the cricothyroid membrane, a small nick taken. Tuhi's needle was used to puncture till you get a pop and the air was aspirated, confirming that your tip of the needle is in the trachea now. Introduce your epidural catheter through this and retrieve it through the oral cavity. As you can see here, it is passed from here and the catheter is retrieved from the oral cavity. The person is holding the catheter at both ends, which is going through the larynx and through the oral cavity out there. Then the epidural catheter was threaded through the side eye of the infant feeding tube inside, and then slowly the infant feeding tube was pulled out, making the epidural catheter go from the cricothyroid membrane all the way up the larynx, oral cavity, and retrieved from the left nostril out. So now the epidural catheter was there, ready to railroad the tube over the same. Make sure that this end is either caught in the artery forceps, or we used to, apply this connector there so that, by mistake during pulling and introducing, it does not, the completely catheter should not come out from this side. So you always used to secure this end with either the connector or the artery forceps. And then the tube was threaded over the epidural catheter slowly. And once it was adequately in, you attach your circuit and the connector and the capnograph. As you can see, the catheter is still kept in C2 even when the tube is in, confirming the position with the capno and the circuit attached. You can see that it's in, and then we had anesthetized the patient. Post-op, again, this patient was not extubated on table. He was on TPs in the recovery area with the epidural catheter still acting as the railroading guide. Once he was wide awake, breathing adequately, he was extubated, but the catheter was still kept in C2. Patients usually tolerate this catheter well, if you keep for a few hours, even after the tube was removed. So that was of the catheter ready. And after once you're sure that he is breathing adequately, you're not going to need reintubation, the epidural catheter was pulled out as well. Now this is a short clipping where you can see the retrograde kit, what is available in the market now. Can everybody hear that?
There is no volume, Falguni.
I don't know how to share the volume of the clip actually.
Can you?
Can I just say that?
Of course.
No, the volume is. I mean, I think I will just talk along with that because I don't know how to share the volume of the clip.
That's okay. Please say about it.
Yeah. So he's palpating the cricothyroid membrane, puncturing that with the needle, 45-degree angle, introducing the guide wire, which is available in the kit. Now it may come out from the mouth or nose. More often it will come out from the mouth, of course. So that is retrieved. And he's clamped it, as you can see, with a artery forceps here, so that the accidental pulling out of the wire is prevented. And then he's threading the tube from the Murphy's eye till you get a gentle resistance, and then introduce it. And once he's sure that he's in the larynx, he has removed the wire, because this wire cannot be kept so easily as the epidural catheter. Epidural catheter is much softer and pliable. However, these wires are a little firm. So that was all about the retrograde intubation and the various awake intubation techniques that one may have to use. I've not covered fiber optic intubation in detail here because I think that has been covered in various other topics, and that most of us know. I thought about covering these because most students would not have seen these techniques. A bit about Down syndrome anesthesia, because there was one long question asked once in DNB for anesthetic management of the patient for dental extractions in a case of Down syndrome. So I just thought I'll cover these quickly. As we all know, Down syndrome is a chromosomal disorder which was described way back in 1866. And the commonest genotype is trisomy 21, which is the most common one. They have short stature. They are usually obese. Generalized hypotonia is present, legs, joints. So these are the points to be kept in mind. They have flat occiput, brachycephaly, short neck, low set ears, flattened nasal bridge with mid-facial hypoplasia and protruding tongue. All these features may make your mask ventilation and your intubation laryngoscopy difficult. Prominent epicanthal folds, upward slanting eyes, brushful spots, simian crease, sandal tap, etc. So these are the diagnostic features of patient with Down syndrome. This is again the diagram showing the same. Very often they also have some cardiovascular anomaly, congenital cardiovascular anomaly, the commonest one being VSD, sometimes PDA, ASD, and even TOF at times. They have increased chances of pulmonary artery hypertension because of the left to right shunt. There can be secondary chronic hypoxemia due to repeated LRTIs, OSAs, and hypoventilation due to muscle hypotony. If Eisenmengerization has happened, then they have very high mortality under GA, and these are really high risk groups and need to be taken into tertiary centers with ICU backups and everything if the surgery is an emergency. And they are at increased risk of infective endocarditis prophylaxis. So infective endocarditis. So the prophylaxis has to be given to these patients when they are taken up for dental procedures. They can have respiratory illnesses, which is one of the commonest complication happening in Down syndrome patients, which ultimately proves to be the reason for their death, so repeated infections, etc. And this happens because of anatomical features like macroglacia, crowding of mid-facial structures. They have high arched palate, micrognatnia, sometimes choanal stenosis, narrow nasopharynx. They have lingual tonsils, short broad neck, subglottic stenosis. All these, again, as I said, are reasons for our difficult ventilation and intubation. And very often they have OSA as well, which usually appears in second and third year of life due to narrow upper airway, poor pharyngeal muscle tone, tonsillar and adenoid hypertrophy. They have recurrent respiratory tract infections and aspiration, which can progress to sepsis, pneumonia, sometimes interstitial lung disease as well, and even death due to these complications. Other congenital anomalies that may coexist with them is tracheal bronchus, then congenital tracheal stenosis, laryngomalacia, tracheomalacia, subpleural lung cysts. They are often known to have cervical instability, which is an important point to be kept in mind when we are managing the airway. It involves atlantoaxial and atlanto-occipital instability due to laxity of the transverse atlantal ligament. Bony abnormality and increased risk of C1C2 subluxation is seen in them. And the atlanto-dense distance as seen on the X-ray, which if the distance between these two is less than 4, usually it is less than 4.5. And if change in neck position causes it to be more, then they have more neurological manifestation of spinal cord compression like hyperplexia, abnormal gait, extensor plantar neurological bladder, quadriparesis, and sensory loss. So the neck movements in them need to be minimized, and one need to manage their airway in neutral position as far as possible. Then they have various GI symptoms as well, like swallowing dysfunction. So they usually come with drooling saliva, etc. They have esophageal dysmotility or GRD-like symptoms. it's very common in them, then therefore it can often lead to aspiration pneumonia and obstruction. They have OSA, they have recurrent aspiration, they may present with wheeze, chronic cough, recurrent pneumonias, etc. And the other congenital GI abnormalities, which sometimes do coexist, are esophageal atresia, duodenal atresia, anorectal malformations, and Hirschsprung disease. They have decreased cholinergic and serotonergic activity, developmental delay and mental retardation at times, microcephaly, increased risk for seizures, generalized poor muscle tone. Alzheimer dementia is frequently seen if you have some older patient with Downs. And these are the patients who have limited capacity for verbal and behavioral expression of their painful stimulus and reduced nociception. Even the endocrine system is at times affected. They have autoimmune hypothyroidism. Hematologically, they may have lymphoblastic and myeloblastic leukemias. They are more prone to incidences somehow more in them. Polycythemia is common in smaller babies with Downs. They have various ophthalmic and hearing issues as well. So one need to preoperatively assess and document all these during the pre-op checkup. Now, when it comes to giving anesthesia to them for dental procedures, they are to be taken in dental chair in dental office only if they belong to ASA 1 and 2 categories after complete thorough pre-op assessment, examination and investigations. Otherwise, they have to be admitted and they have to be taken in OR for the anesthesia and the dental procedure. Make sure that all the emergency medicines are available and check your equipment and machine. Conscious sedation can be given if there is some mild form of Down syndrome where they have ability to communicate well, they have reasonably good IQ, and they have good muscle, fairly good muscle tone and swallowing reflexes. Then only these patients are given conscious sedation, which can be achieved by various drugs, oxygen, nitrous oxide, or combination of both. Routine anesthesia assessment to be done, detailed history, high index of suspicion for any congenital heart defects, and when in doubt, please do complete cardiac workup in the form of ECG to the echo. Detailed airway examination, look for the features of difficult airway. Check your on-air SpO2. Complete blood count, X-ray chest, X-ray chest, thyroid function test to be done in these patients, irrespective of their history. If in doubt about the cervical spine instability because of restricted movement or some kind of symptoms, do a cervical spine X-ray as well. And an informed consent must be taken by the patient as well as the relative and inform them about the adequate fasting hours prior to the procedure. Now, the various problems that we face, and all the more so in these patients for dental chair anesthesia, is reduced venous return because of sitting and semi-sitting positions, leading to more severe form of vasovagal attack due to pain in case they get syncope. Increased chances of air embolism in sitting position, especially in patients with congenital heart defects and shunts. Unprotected airway, which is shared by us, patient can aspirate because as it is, their swallowing reflex and is not adequate. They have hypotonia of muscles. The sphincter tone is not good as well, so they may regurgitate very more easily than others. Increased incidences of arrhythmias, nasal bleeding if nasal intubation and airway is used to deliver anesthetic agent. The various instruments and the used by the dentist may sometimes, kind of act as a foreign body obstructive agent. Difficulty in initiating CPR if patient is in sitting and semi-sitting position and goes into severe hemodynamic collapse. They have higher incidence of infective endocarditis with their congenital heart diseases present many times. They have increased chances of cerebral hypoperfusion and hypoxia and therefore need to be treated and ventilated adequately. So make sure your equipment are at hand when you anesthetize such patients in your setups. And risk of anaphylaxis is always to be kept in mind. Patient position, etc., is more or less same as for any other patient when it comes to general anesthesia, but keep in mind the chances of airway obstruction due to tongue fall is higher in them pharyngeal soiling and aspiration, as I said, because the swallowing reflex is not adequate. All standard routine monitoring, give good anti-sialogogue agent. LMA can be used if mouth opening is adequate and the procedure is short and one-sided. You need to though pack the area. Use second generation supraglottic airway whenever possible. Otherwise, more or less, the steps of GA are same. Keep in mind the cervical spine instability. So use jaw thrust instead of head to chin lift and the triple maneuver when you have the cervical spine instability. Make sure they recover well and meet all the recovery criteria, and they are accompanied by an adult when you discharge them. So the key points for dental anesthesia, whether it is in dental office or it is in your operating room, whether it is child or whether it is adult, whether it is a normal individual or whether it is mentally challenged or patient with severe illness, the key points to remember are: you should have a very good patient rapport. You have to meet them, talk to them, optimize the conditions. You have to make them understand what you're planning to do and why you're planning to do whenever possible. Thorough pre-op medical history and airway assessment. Protocol for airway management has to be in place, and your plan A, plan B, plan C has to be ready with all the equipment and the adequate skilled manpower to be around. Local airway anesthesia to be used adequately. Awake intubations and awake extubation whenever difficult airway is suspected. Intense post-operative monitoring and adherence to discharge criteria in whether it is daycare surgeries or office procedures is of vital importance. It's challenging and may put everything to test at times, be it knowledge, experience, patience, or skill. Innovations and modifications of routine protocols thus become mandatory, and a teamwork between the anesthetist surgeon provides the key to success. Thank you so much. Kalpana, can I stop?
Yeah. Thank you, Dr. Falguni. I think we have covered this topic in such detail that if the students look at these PPTs, I'm sure they'll be able to fill up any of the questions asked in the DNB exams.
I tried to cover the theory paper, often asked questions which are usually on dental chair, enteronox, Down syndrome for dental care, and at one place it was congenital heart disease for dental procedure. And of course, this ankylosis and submucous fibrosis, etc., come as short cases very often on your practical tables. So I just thought I'll have an overview of all, and just to give them an idea that, and at the same time help them with their clinical practice when they start practicing on them. So I try to achieve the balance. Hope it is going to be helpful to them.
It was extensively covered, really extensively covered. Very well, and very much good justice done to the whole topic. Any comments from any of our senior teachers?
And I take this opportunity to say that most of my dental anesthesia I've learned from Dr. Halbe and Dr. Lehri. So, and one of them is here very much with us. So, Madam, I would like to have your comments on this.
Yes, Falguni, excellent, really excellent. I'm so proud to see everything. So proud to hear you also.
Madam, it took me back to our dental anesthesia
Yes,
days, actually.
very much, very much. So I think she has covered most of it, most of it. Only thing, Falguni, you must say about the small, see, still in Mumbai, the private clinics, they are practicing anesthesia. What we always talk now, we always talk about the big hospitals. Okay. So private clinics also they have. So you must say ki what are the prerequisites there before starting anesthesia. Okay. Means like they do not have many of them I see around. Sometimes I just peeped and I see they had written down here in the Shivri. I live in Shivri. So general anesthesia ke niche anesthesia के लिए क्या नहीं हम the anesthetist brings the cylinder, both the cylinders, blue and black. There is no whatever it is, anesthetist bring everything. So that you must say that ki this is very mandatory, and these are the basic things one has to have before starting, even in a small dental clinic. And record keeping is very important in small clinics. That's it. I think everything you have covered.
Sure, ma'am. Yeah.
Absolutely.
Sure, madam. That's an important point to be noted, because these children will go out into practice soon, and some of them may go into freelance.
Yeah, some of they still have, no? In Bombay, proper Bombay also they have in a small clinic.
Right.
Yeah.
Nayak madam, Daigude madam.
Yes, Falguni,
any comment?
covered the topic extremely well.
Thank you, ma'am.
Can I say something?
Yes, ma'am. Thank you. Yes, madam. Definitely.
Back from UK. In UK, we used to do dental chair anesthesia with entonox and all that. But I don't think private clinics, they keep entonox. So anyway, one of the dental surgeon asked me to give anesthesia for kids. So I asked him what kind of duration you will need. So he said maybe 1 hour, because 2-3 drillings, fillings and all that. So I convinced him we will do all these cases in the nursing home. And those days I used to carry bag and bottle and ether. Which of course intubation and all that. But and then later on, when I started working in Bombay Hospital, we had lots of interesting cases like autism and previous head injury, and so these patients are some syndromic children.
Correct.
Where they have infections on and off during childhood, and then they come up at the age of 7, 8, 9 with a lot of teeth absolutely needing treatment. And those cases, the surgeon would take more than 2-3 hours, 4 hours. So in those cases, of course, we did proper nasal intubation. And so one case which I would like to tell you particularly, I did one epidermolysis bullosa. That girl was about 13, 14. And because you know what the condition is like, they with slightest friction, they get the skin bullae and then they burst open, they get infection. And so all these years she was going through all that. And ultimately she had lost her fingers. She had lost her feet. And so we had to give her, and of course, you have to take care of the skin, mucosa, everything. So in fact, when I talk next time, I'm going to show the pictures and everything. So I'll give all the details. But just to say some, in conclusion, we had to take extreme precautions not to have any sticking plaster anywhere in the body. And even IV cannula was fixed with the cotton tape, and the tube was of course fixed with the cotton tape. The blood pressure cuff, because that patient took nearly 4 hours. Most of the teeth were gone and needed drilling, filling, capping, everything. So even blood pressure cuff, we had to put Gamgee first and then put blood pressure cuff. And even ECG leads, we had to, kind of put the tape around, cotton tape around the whole chest, just to keep it in place. And a table was covered with the Gamgee and all kinds of things. Then I had to put a lot of jelly on the lips and on the laryngoscope. Actually, I had one plastic laryngoscope, which I had brought it from there, which doesn't have a, it's not a metal blade. So it didn't have a sharp edges. So I used that for the nasal intubation. And of course, it was a very good challenging case. And I made a poster for one of our World Congress. So I will show the pictures next time when I talk about some other topic. Okay. But it went off very well, and her hemoglobin was only 5.6, 5.7, something like that. So previous day we had to give 2 bottles of 2 pack cells, and then we had taken the child, and the cannula was, sort of fixed with the gauze roll or a cotton tape. And it was a, very kind of stressful case. It went off very well. Thank you.
Thank you, ma'am.
I think
Madam Nayak
madam wanted to make some comments.
Yeah. Kalpana, can I make a comment?
Please, madam, please.
Can Falguni hear me?
Yes, I can hear. Yeah.
Yeah. In Shah hospital, we used to get innumerable cases of temporomandibular ankylosis, submucous fibrosis, and Pierre-Robin syndrome also. And when I was doing pediatric anesthesia. So
Right.
we had there is one type of I don't know. I just must have missed your slide. I used to induce these babies and attach the tube to JR circuit. See, that was we didn't have all these newer gadgets for intubation. We had only pediatric.
Madam, your voice got muted. Madam, you are muted now.
Sorry.
Yeah.
So after induction, I used to attach the JR circuit to the tube and pass it through one nostril and watch the bag movement. And when the bag movement is maximum, you fix the tube there. So baby goes to like a good depth of anesthesia. Then you pass the fiber optic from the other nostril and intubate. Like that. If you think of it now, luckily, God's grace, none of them had apnea or respiratory arrest. God only knows what I would have done. But all these cases, very many cases used to come as a temporomandibular ankylosis for dental surgery. Dr. Dusia used to do cases. So this is the way I used to, luckily I had a pediatric fiber optic, so we could do it. And second comment is, you are Dr. Alka Halbe's student?
Yes, madam.
Alka is my student. So,
Yeah.
granddaughter.
So I'm your grand student, madam.
Very nice. So I'm very proud that you presented so well.
Thank you so much, ma'am. Thank you. Madam, we are blessed to have you all around.
Falguni, next time have one of your past students present something.
Present.
I think that will
be fourth generation.
Yes.
put it on
generation student.
Anesthesia news,
Yeah, full generation student.
Yeah.
Nice session today. I enjoyed. Nice.
Thank you. Thank you so
Very
much,
well
madam.
presented, Falguni. Very well presented.
Yeah.
Thank you, madam. Thank you.
Do the residents have any comments to make? Any questions to ask?
Yeah, Resident should ask questions.
Do we know you are here? You are sleeping? We are speaking to black boxes. Yes.
One method I would like to say for TM joint, what we had done, the surgeon would, of course, do the release procedure fast. So in those cases, just to keep the patient under for about 10-15 minutes, what we had done, we put in a cuff tube nasally into the esophagus, and we inflated the cuff, and the other tube to the other nostril into the oropharynx, or near the, if we could, of course, the patient was on spontaneous, near the, instead of, spending a lot of time on blind nasal intubation, we did couple of cases like that. Okay. So the basically gases would not go into the GI tract, because these patients had almost not even more than a centimeter of opening. So the gases going out from the mouth were very little. I mean, mouth, you just keep it closed. And we connected it to the JR circuit. So we could see the movement properly. And we just kept the patient on spontaneous with the tube in the near the trachea, you can say. Right. And the patients did very well. And as soon as he released, we put the tube in the trachea.
Madam, hey, for this dental, na, this is they have a bony communication also. It's not just a fibrous communication. So they need lot of burring. They do burring, they do condylectomy. Like there are two processes, na, mandibular process and what is the second process called? The temporal process.
Coronoid.
Coronoid and condyloid. Coronoid and condyloid. So that coronoid process, they take it out always, and then they do it. So that it takes very long. For at least the dental people used to take very, very long. We could not take chances. But this is a thing if you fail to intubate, maybe this can be tried.
This is like the combative principle, you know. It's like a combative principle, madam.
Yes.
That you block the esophagus.
Actually, basically, these were done in the children who had contracture because of the burns and all that. You know, which could be released very fast.
Fast. Correct. Interesting. Any question from students?
Sleeping or ran away? Not saying anything.
Number is going down.
Yeah, actually those junior, na, 4 of you, I want to talk to you all regarding vaccination. Shweta?
Nobody is there.
They are not there, looks like. Asit?
They are logged in, but they are run away.
Yeah, they are ran away, looks like. Om. And which is Sanket. You know something we have to do, Kalpana, for this students. They are going at 7 o'clock in the morning, coming back at 8:30 at night, every day for this vaccination. See, they are not there, they ran away, looks like.
Anyway, but I will talk to them once we meet them tomorrow, maybe in person if you are.
Tomorrow do you have a case?
Yeah, I'll be coming, so we'll meet them in person.
What time? I'll come because I don't have anything, but I'll come.
Madam, 10 o'clock, 10:30. Okay.
Thank you, Kalpana.
Thank you. Falguni, I want to thank you immensely for a lovely lecture that you have taken.
Thank you so much.
The topic so
my pleasure.
And I think for me, it was like a revision for me. So many things I did not know. Or I might have forgotten, I don't know. Because we don't practice dental at all. Right? It was fantastic. And your slides and...
My pleasure.
Very good. Thank you so much.
Thanks were very good.
All the senior madams, thank you so much for joining us back again.
Thank you. Bye, madam. Bye, Kalpana.
Bye, everyone.
Bye, madam. Bye. Thank you, everybody.
Bye.
Bye.